Yeah, so the dapro study was actually part of the ASCEND clinical trial program that led to the development and ultimately approval in stable dialysis patients of Daprodustat. This was a HIF-PHI, prolyl hydroxylase inhibitor. It's an oral agent that's used to correct anemia and was tried in patients on who are incident dialysis, stable dialysis, or in non-dialysis patients. And what we presented at the National Kidney Foundation was the data on hyperresponsive patients in the ASCEND-D, or the stable hemodialysis study. Essentially, the reason we thought this was important is that about 10% of patients on hemodialysis are hyper-resistant, are hyper-responders to conventional erythropoiesis-stimulating agents. And so the question was, in this context, how does Daprodustat do? Does it work in ESA-hyperresponsive patients? Are there any aspects of the response that are particularly notable as contrasted with stable ESA patients? And what we found was that in stable hyperresponsive patients, where hyperresponsiveness was defined by the erythropoiesis resistance index, which is basically the dose of erythropoietin that's weight adjusted divided by the weight by the hemoglobin, dose adjusted divided by the hemoglobin, that there was no difference, that the number of dose changes was similar. It was true that, as one would expect, higher doses of both ESA and Daprodustat were needed, but the dose changes were no different. So it works in erythropoietin hyperresponsive patients. Well, the US FDA approved this drug for use in stable hemodialysis patients 4 months after starting dialysis. Mostly the patients who are going to have a dosing with Daprodustat orally are going to be stable peritoneal dialysis patients or patients on home therapy. But it could be that, based on contracts with dialysis providers, it could be that it'll be used in-center dialysis patients. And the idea here would be that you can use it in hyperresponsive patients, that it works, and it's effective. Yeah, so this study, that was sponsored by Bayer, looked at the non-steroidal mineralocorticoid receptor antagonist Finerenone and its use in the United States. And the data set that we utilized was the Veradigm Network electronic health record database, which covered 50 states and about 15% of US ambulatory practices, so large data set. And we analyzed about 20,000 patients. And what we found was, or what we observed was, that Finerenone is underutilized across the United States, but that the underutilization seems to be more, it seems to be somewhat non-uniform, more marked in the Midwest states. And that it also varies by provider. So the most frequently provider for using or prescribing this drug are primary care doctors, followed by nephrologists and diabetologists, but cardiologists are very infrequently using the drug, despite the fact that this drug has impact on cardiovascular endpoints like heart failure hospitalization, as well as slowing the progression of kidney disease, for which these two indications it's approved. And so how do we explain this? I think part of the explanation is the lack of awareness. Part of it is because, like most mineralocorticoid receptor antagonists, there is a possibility of getting hyperkalemia events. It's much more marked with the steroidal mineralocorticoid receptor antagonist, spironolactone, and only occurs in a smaller fraction, although higher than placebo. And the number of events of hyperkalemia that require discontinuation of the drug or serious enough to require hospitalization, a very few, very small percentage. So broadly speaking, it seems like a pretty safe drug to use, but it's still being underutilized. Other reasons could include the fact that the cost is quite high, and getting pre-authorization is difficult, at least for some providers. So there's also a disparity. So less well-resourced places might not have the support structures in place to get it approved by a pharmacy provider. So cost of access and the concern about hyperkalemia probably explain why it isn't to be used. But I would say the guidelines clearly indicate that it's one of the pillars, right? So there are 4 pillars in slowing progression of kidney disease among type 2 diabetics. It's renin-angiotensin inhibitors like ACE inhibitors and angiotensin receptor blockers. It's SGLT2 inhibitors. It's nonsteroidal mineralocorticoid receptor antagonists. And then more recently, there's evidence from the FLOW study that GLP-1RA, like semaglutide, seems to be effective. So these 4 pillars are now part of the guidelines from KDIGO and also the American Diabetes Association. Yeah, so I think the first thing is to identify the patient at risk. And for this, the National Kidney Foundation heat map is really helpful, right? So you see the heat map and it has color codes, and the high-risk patients are defined in the ones in that heat map that are red. And once you define the high-risk patients, you definitely want to be using the 4 pillars of therapy, including Finerenone, to try and slow progression in these very high-risk patients. And it should be guideline-directed, right? So the NKF, the KDIGO guidelines, the American Diabetes Association guidelines all recommend it should be used, and it should be used as part of the 4 pillars approach. I think what's not clear is, should you be using all 4 agents? Should be using some fraction of those 4 agents? In heart failure management, cardiologists are very comfortable having patients on 4 agents to prevent heart failure. But we still have to embark on that more comprehensive approach. But I do think that you want to try and maximize the opportunity to slow progression kidney disease in patients, particularly among type 2 diabetics, because they progress quite fast. And there's a large proportion of patients in the US with type 2 diabetes with kidney disease.